With this, we move on to a panel discussion today. And the panel discussion would be on the Indian burden of atherosclerotic cardiovascular disease. And the panelists for this particular scientific session are Dr. Bappaditya Kumar, who is an interventional cardiologist, Nightingale Hospital, with an overall of 20 years of experience. He's also attached to Manipal Hospital, Broadway, Nightingale Hospital, and he has published original articles and several papers and has been a faculty at national and state cardiology conferences. I welcome you, sir, on stage. I welcome the second panelist, Dr. Arijit Ghosh, who is a cardiologist with an experience of 22 years attached to Manipal hospitals and several other hospitals and clinic. I would like to invite the third panelist, Dr. Sabyasachi Paul, interventional cardiologist associated as senior consultant in cardiology at BM Birla Heart Hospital. He has overall of 21 years of experience. Our fourth panelist today is Dr. Ayan, who is an accomplished interventional cardiologist specialized in advanced cardiac procedures, attached to RN Tagore Hospital with an overall experience of 14 years. And to moderate and chair the session, the panel, I would like to invite Dr. B.P. Pandey, who is a senior interventional cardiologist and founder member of Indian Academy of Echocardiography. He is also the secretary and founder member of Howrah Town Diabetes Study Society, and he has a vast experience of 31 years. I welcome all our panelists and our chairperson today on stage.
Request Bappaditya to have his presentation, then we'll make a panel discussion. So sort of a combination of a panel come lecture.
Thank you, Pandey sir. At the outset, I would like to thank the Howrah Diabetic Society for the invitation. So basically, this is a panel discussion, but I would like to go through some slides quickly. So I have tried to make a collage of some newspaper cuttings, so which demonstrates the ASCVD burden in the Indian scenario. At the top left, you can see some cuttings. Heart attack claims 80 per day in Mumbai. Another headline says, lifestyle triggers heart problems in Mumbaikars. One cutoff from Hindustan Times, India staring at killer lifestyle epidemic. One from the Times of India, number of cardiac patients below 40 years on the rise. And the last one on the right side, you can see a Gujarat-based cardiologist, 41 years, whom we met at conferences, dies of a heart attack after doing a primary angioplasty. So in short, this is the burden of ASCVD in India. I have passed almost 1 minute now speaking. By this time, there is almost 34 patients have died of ASCVD around the world, and 8 to 10 patients have died in India. So this is the incidence and mortality of ASCVD or cardiovascular disease in the Indian scenario, where every minute around 10 patients die in India. CVD is the leading cause of mortality globally. CVD has claimed more lives in 2019 than any other communicable disease combined. 18.6 million patients have died of CVD in 2019, and it is estimated that almost 2.4 crore people will die around the world by 2030 every year. ASCVD is the leading cause of CVD mortality and morbidity. This I was telling. In the past 60 seconds, 34 people have died of AMI or stroke around the world. Now, the important points, the salient points where Indians differ from the rest of the world, the burden due to CVD in India is remarkably higher than the global level. The age standardized death rate for CVD in India is 282 versus 233 around the global levels. CVD-related age standardized disability-related loss of life years is around 1.3 times the global average. Nearly 2/3 of all CVD deaths in Indian population are premature, that is less than 55 in male and less than 65 in female. Indian presence with CVD a decade earlier compared with the European ancestry. So these are the salient points where CVD in India differs from the rest of the world. Why is the CVD epidemic in India a matter of concern? Because of the huge economic losses India would suffer. Between 2012 and 2030, it is estimated that India will suffer $2.17 trillion because of this CVD. Coming to the burden of non-communicable disease and annual mean, OOP means out-of-pocket expenditure. So out of the total out-of-pocket expenditures, CVD accounts for almost 30 to 40%. That means the economic burden of NCD is notably high in terms of out-of-pocket expenditure and community health expenditure, but it is mostly due to the CVD and stroke. Almost 40% out-of-pocket expenditure for the people are because of these two diseases. So prevalence in India of dyslipidemia, 80% of Indians have dyslipidemia. Moreover, more than half of cardiac deaths in India is occurred below 50 years of age. High cholesterol is present in 25 to 30% of urban and 15 to 20% of rural subjects. So this was an important study published by the ICMR. The ICMR India study published in Lancet 2023. 213 million people had hypercholesterolemia in India and 185 million people had high LDL cholesterol. This is a small study on the right hand side from Bengaluru, Indian study, which showed that 6 in 10 Indians were suffering from high LDL cholesterol. So this is the burden India is facing. This is a very important study. The ICMR India study in 2023, basically it was a diabetic and pre-diabetic study, but from this study we can have an idea regarding the prevalence of hypercholesteremia, hypertriglyceridemia and LDL across the Indian scenario. You can see there was much state-wise differences across India, some states reporting higher incidences of hypercholesteremia and some states very low incidences. Highest prevalence of highest total cholesterol was seen in Kerala and Himachal, whereas the lowest was seen in Jharkhand and Assam. West Bengal remained in the middle zone across all the levels of cholesterol. Risk factor was CVD epidemic in Indians. This is beyond the scope of discussion, but just keep in mind CVD epidemic in India is because of some inherent biological risk as well as some population level changes. Population level changes occur at 6 major transitions: economic transitions, nutritional changes, socio-cultural changes, environmental changes, demographic and epidemiological. So all these together results in the higher incidences of CVD in India at lower age and higher mortality. We cannot discuss CVD in India without discussing atherogenic dyslipidemia. What is atherogenic dyslipidemia? High triglyceride levels, low levels of LDL cholesterol, more or less normal levels of LDL, but increased number of cholesterol depleted small dense LDL particles. So this is in short the atherogenic dyslipidemia seen in the Indian scenario. Pure study was another study done across 80 countries around the world. It showed that if we see the global data, hypertension was responsible for CVD in 22% patients, whereas it was responsible for 14% in the South Asian population. At the same time, high non-HDL cholesterol was important in the Southeast Asian regions, whereas it was not so important across the global scenario. So these are some few differences between the global and the South Asian regions. So important CAD risk factors, we can get an idea about these risk factors from InterHeart and Pure studies. InterHeart we all know, it was a landmark study. Pure study was published just 2023. More or less the similar risk factors are seen. Just keep in mind from the Pure study, one important thing came up, non-HDL cholesterol. Non-HDL cholesterol is very important for the Indian and the South Asian regions. Relative risk of acute AMI, in our scenario, ApoB by ApoA1 ratio is very important. Now coming to another important thing, high risk of recurrent events in the ACS patients. This is very important. After a primary event, first 90 days are very important because during this time, 1 in 10 patients reported a second AMI, a stroke or CV death within the first 90 days after experiencing an AMI. This is the area where we can improve a lot with our lipid lowering therapies. Life expectancy ASCVD patients is impacted due to increased risk of these recurrent events. Patients with AMI, ischemic stroke had 2 times more risk of MACE events versus the other ASCVD patients. 11.3% of patients with ischemic stroke had a recurrent ischemic stroke within 1 year. So this is the reason where we must be very careful in treating our patients who are already at a ACS or a ischemic stroke. Dyslipidemia and LDL cholesterol prevalence and its role of LDL in AMI and ischemic stroke is beyond any doubt. Lipids are one of the most critical modifiable CV risk factors. You can see this was the InterHeart study. Most attributable risk was due to the dyslipidemia. High LDL has been established as a key factor, and each millimole reduction, that is each reduction of 38 milligram per DL of LDL reduces the risk of ASCVD events by 10% during the first year, 16% after second year, and 20% after 3 years. So this is the reason why we must stick to lipid lowering therapy as early as possible, and we should titrate the lipid lowering therapy according to the LDL levels. Unmet needs in Indian patients, post-ACS patients not on target LDL levels despite statin therapy. This is a matter of concern in the Indian scenario. 575 patients from 11 sites across India had an ACS with hypercholesteremia and were followed up for 1 year. 80% of patients did not achieve the target goal of less than 55 milligram per DL as advocated by the Lipid Association of India guidelines or the ESC guidelines. 96% patients were initiated on high-intensity statin, no patient was on PCSK9 inhibitor, and the major reason of statin dose reduction was perceived improvement in lipid levels. This is very important. Barriers to achieving target LDL levels and lipid lowering therapy. This study was done with 5,900 patients and online conversations. Some interesting things came up. Belief about LDL. 53% patients believed that there was no agreement of what level is dangerous. 50% believed that very high level of LDL is hereditary. At the same time, 57% believed the diet was better. So these are some of the these are some of the thoughts process of the patients regarding these LDL levels. At the same time, there were some barriers to medication in pre and post CV events. 59% believed cost was an important thing that resulted as a barrier to medication. 55% believed that it was not needed. There are some patients who believe that side effects was there to medicine and need not take the medicine in such doses as prescribed by doctors. So these are some of the thought process of the patients as well as some of the healthcare providers that lead to barriers in achieving the target LDL levels. So therefore, it is crucial to raise patient awareness about the significance and ideal target levels for LDL cholesterol goals and medication adherence. Failure to attain the guideline recommended LDL levels. This is from the Da Vinci study done in European countries. In Europe also you can see that only 33% patients reach their risk-based goal. So that means if you include all the primary and secondary prevention, only 33% patients reach the LDL goal. At the same time, if you see for secondary prevention, only 1 in 5 patients achieve the risk-based goal. So this is the data from the European study. You can just imagine regarding the Indian scenario. So what are the reasons regarding this failure to achieve the LDL goals? Lack of healthcare physicians' familiarity with guidelines, high cost of medicines, patients' reluctance to be treated with high-intensity lipid lowering therapy, and concern about statin-related adverse effects. So in summary, CVD claims more lives than other non-communicable diseases combined. In India, more than half of the cardiac deaths occur before the age of 50 years. Studies show that 80% of Indian ACS patients do not reach target LDL goals even a year after the CV event, and it is thus essential to prioritize lipid lowering in Indian patients and ensure adequate escalation of therapy. Thank you.
Thank you, Bappaditya. Please join us here. I'll take this opportunity as a secretary of the society. I'm requesting Dr. Soumitra Rai to have his presentation so that we can take further panel discussion after his lecture. Professor Shantanu Guha, is he available? He's coming. So once he comes, please ask him to join the panel, and we need a chair. Ekjon kauke একটা chair দিয়ে দাও. Dr. Soumitra Rai will be speaking on diabetes and cardiovascular heartbreak in motion, and then we'll take the LDL discussion further on. He has got a very pressing commitment actually, so
thank you,
I'm
Dr.
just
Pandey,
taking this liberty.
And the whole group, Dr. Bera, and everybody, Jayati, and all the chairpersons over here. Thank you for accommodating me. Now there's a trick here. You see the heading is very tricky. Heartbreak in motion. Now it's subject to interpretation. Interpretation by the speaker, interpretation by the chairperson, interpretation by the scientific committee. So I thought it is heartbreak in motion and B-R-E-A-K, not B-R-A-K-E. So motion and break. So is it heart failure? Is it cardiovascular disease? Something related to heart and diabetes. Okay. So I took it in that spirit. And so heart break in motion. Very, very catchy name though. I'll adopt it later on. Now we know that CKD, CVD and diabetes, they are driven by a combined effect of metabolic, hemodynamic and inflammatory and fibrotic factor. There are loads of factors nowadays. Nowadays we are calling it CKM, and obesity is another fourth angle. So nowadays when we talk about diabetes, at the same breath we talk about CKD, we talk about CVD, and we talk about obesity. We cannot discuss them separately, but for time's sake and for the heading, I kept the CKD and obesity part slightly apart and kept the diabetes and CVD together. Thank you, Chairperson, sir. So, drivers of CKD and CVD in diabetic progression, there are hemodynamic factors like elevated blood pressure and intraglomerular pressure increase. There is inflammation and fibrosis, and there is poor glycemic control. All these can lead to CKD progression and CVD progression. CKD progression how? By tubulointerstitial damage and inflammation, by glomerulosclerosis, mesangial expansion, glomerular hypertrophy, all those fifth year medical college days, you can remember how we talk that diabetic kidney disease and Clemens-Still-Wilson syndrome and those things. Now CVD progression is myocardial fibrosis, atherosclerosis, vascular stiffness and ventricular hypertrophy. So these are distinctly two distinct pathology you can see. One is myocardial fibrosis and another is atherosclerosis. These are the two arms of cardiovascular disease in diabetes. And if we try to find out the epidemiological link of diabetes, obesity and CVD, you will see in CVD and diabetes, about 30% of people with coronary disease have diabetes. And if you see one step up, 32% of people with diabetes have coronary disease, cardiovascular disease. So 1/3 either way. So what to do, I'll tell at the summary. 50% of death related to diabetes are due to cardiovascular. And if we bring the obesity into factor, more than 2/3 of death related to a high BMI are due to cardiovascular cause. And 1/3 of people living with obesity have diabetes. So you see how intermingled all these three pathologies are. There was a captured study which was very interesting, showed the high incidence of cardiovascular disease in people. What I just said, that 1/3 of people with established cardiovascular disease have diabetes, and 90% of people with established cardiovascular disease and diabetes are actually having atherosclerotic disease, not valvular heart disease, not pericarditis, not heart block. Cardiovascular disease is the most common cause of death of people with type 2 diabetes. 1/3 of cardiovascular death affects 1/3 of people with diabetes and 86% of atherosclerosis, as I already mentioned, just to emphasize the point. Now here, this is interesting. About 20% of people with diabetes experience their first cardiovascular event within first 5 years. So it's not a long-standing diabetes which actually eats out the organs. Even within a few years of diagnosing diabetes, you anticipate a huge problem, and the problem you see, peripheral artery disease is the commonest cardiovascular disease which occurs in diabetes, about 16%, stroke around 15%, heart failure about 14%, angina in 10%, non-fatal MI in 10%. These are within 5.5 years of diagnosis of a diabetes patient. Of course, there is overlap. Otherwise, 16 plus 12 plus 12 plus 15 plus 14 will cover everybody. So there is overlap, but you see what is the proportion of patient suffering from cardiovascular disease soon after diagnosing type 2 diabetes. So this is very scary for all diabetologists. Now, type 2 diabetes and atherosclerosis, why they are so intermingled? There is common soil hypothesis. What are these common soils? Smoking, sedentary lifestyle, dyslipidemia, obesity, adiposity, hypertension, as also genetic. So targeting cardiovascular risk in diabetes involves an early multifactorial approach. So it immediately tells you how to prevent the progression of this cardiovascular disease within 5 or 6 years. So you have to do glycemic control. You have to do lifestyle modification. You address blood pressure, you address cholesterol, and you consider platelet inhibition. By this, in the STENO-2 trial it was shown, after 20 years of follow-up, 8 years is an average, that mortality reduced by 45%, which is huge. Time to fast CVD, you can defer by 8 years. Survival increases by 8 years. And microvascular complications obviously reduce. So you address all these issues, and very interestingly, I would say, better HbA1c control is associated with reduction in cardiovascular events. I'll tell you with special emphasis, because we cardiologists are to be criticized a bit nowadays. By the newer advances and with huge enthusiasm, over-enthusiasm, we forget that the primary goal of a treatment of a patient with diabetes is sugar control. That is still the first and primary goal, but we tend to forget that. Of course, we have to look about our heart, our kidney, our brain, our periphery, our nerves, our eye. But sugar control is central. And there was a misconception that sugar control reduces microvascular complication. It does not affect macrovascular complication. Absolutely a myth. Absolutely a myth because of studies and wrong medicines and study designs and so on. It has been clearly shown now that 1% drop of HbA1c can reduce long-term diabetic macrovascular complication in terms of lower extremity amputation, 40% reduction by controlling sugar, 16% reduction of heart failure, 14% MI, and 12% stroke you can reduce by controlling HbA1c from 8 to 7 or 7 to 6. So we have to be careful about sugar control. Anti-diabetic medications have differential impact on the cardiovascular outcome. Metformin suggested cardiovascular benefit. That poor child never got the scope to prove himself because it was not mandatory to sit in the annual exam at that time, and you passed and you actually got from class 1 to class 10 without giving any exam. And when the examination came, said, this chap didn't give any exam. So how can you say he has class 10 pass? So that is the tragic story of metformin. It never got scope to go through exams. Sulfonylurea, proven cardiovascular safety. And that is a serendipity. Somebody tried to prove that sulfonylurea is bad compared to DPP-4 inhibitor, and lo and behold, they proved that they were equal. So sulfonylurea got the whole benefit without spending a single penny. So that's something very lucky, star. TZD, suggested cardiovascular benefit, they improve ischemia, but they deteriorate failure. So balance is your balance. DPP-4 inhibitor, safe, maybe a bit better. SGLT2 inhibitor, proven CV benefit. GLP-1 agonist, proven CV benefit. And insulin is proven CV safe, but weight gain and maybe a bit of heart failure. So they are not bad drugs, all of them. So guidelines recommend glucose lowering therapies with proven benefit in patients with diabetes with cardiovascular risk, GLP-1 receptor agonist class 1, SGLT2 receptor class 1. So independent, and there is a line there, independent of HbA1c, independent of concomitant glucose lowering medication. So even when your HbA1c is 6, patient is not on SGLT2 inhibitor, will you start SGLT2 inhibitor? Yes, I will do. If the sugar falls too much, I will reduce the other anti-diabetic drug. So they will come per se by their own merit. Now GLP-1 receptor agonist and SGLT2 inhibitors have differential mechanism of cardiovascular protection. We now know that GLP-1 receptor, if you activate them, it reduces inflammation, it increases glucose uptake, reduces ischemic injury, increases LV function and heart rate, that is in the heart. And in the circulation, it reduces inflammation, it reduces smooth muscle proliferation and platelet aggregation, and it improves blood flow, plaque stability and vasodilation. Whereas SGLT2 inhibitor, there are different mechanisms on the heart with sodium-hydrogen exchange mechanism, with different kinetic mechanism, with microangiopathy, autophagy, so the apoptosis is reduced. There are so many things. The fuel mechanism, so the ketone bodies get improved. There is epicardial fat, and there are so many theories. So potential mechanism of GLP-1, not only as I told the pathological way, but also grossly by reducing body weight, blood pressure, improving lipid, as well as of course HbA1c reduction. And it has been shown by CVOTs with cardiovascular benefit, all on the left side of the curve. Some got p-value, some did not get p-value, but if you get the meta-analysis, there is 14% reduction, and because of the sheer number of patients, this 14% could draw a p-value of less than 0.0001. For cardiovascular benefit, MACE reduction 14%, cardiovascular death reduction is around 13%, MI reduction around 10%, still p-value is 0.02. Stroke reduction 17%, p-value is 0.0002. You know, that's why differential from MI and stroke, GLP-1 receptor agonist is much more potential in reducing stroke than heart attack. So American Association of Clinical Endocrinologists put, if there is a history of stroke or TIA, GLP-1 receptor agonist and pioglitazone are the top priority. SGLT2 doesn't come there. Stroke has been separated, which has not been separated by ADA, but by AAC. SGLT2 inhibitor, sugar control, pressure control, glomerular hemodynamic, lipid control, uric acid control, all the good things in life can happen. Potential mechanism for improved heart failure outcome. It's almost like taking an apple. An apple a day keeps the physician away. Actually, that is true because apple bark, apple skin contains gliflozin. Perhaps that was the reason that an apple a day gave you gliflozin for thousands of years and you kept the physician away. Now we know the science, maybe. It's a conjecture, but there is a truth behind it. So, how SGLT2 inhibitor reduces? There are a lot of mechanisms. As I say every time I lecture, that when you go to a fantastic restaurant, enjoy a meal, do you call the chef to ask how you made the meal? What is the mechanism of such good taste? You don't. You just order again another dish, you bring your friend next time. So if you are happy with SGLT2 inhibitor, you take it yourself, you give your patient, but don't ask the scientist how it is working. It's useless, wastage of time. DAPA heart failure, you know that it reduces the composite CV death or worsening of heart failure hugely and by day 28. So if you waste 1 week, say come next Saturday, I'll see you next Saturday, today I'm busy, you are losing the time because you are losing 1 week from that 4 weeks when the patient already could have benefited, got a significant benefit. So don't waste time on prescribing SGLT2 inhibitor if you think it is indicated. In DELIVER trial, HEPF patient, same 18% reduction with a huge p-value. For composite endpoint, 18% reduction. Across the range, diabetes, no diabetes. Diabetes becomes secondary. Emperor reduced with empagliflozin reduced. Ejection, 25% p-value. And with diabetes, without diabetes, no difference. Emperor preserved, fantastic value, 30% reduction versus 17% reduction, whether it is mid-range or whether preserved, both have got p-values. The lesser the ejection, greater the p-value. And again, with or without diabetes, same thing. So Emperor, empagliflozin, dapagliflozin, preserved ejection, low ejection, diabetes, no diabetes. Benefit is across the group and at the cost of no extra side effect, maybe a little bit of genital infection, but good hygiene usually overcomes. So ESC 2023 guidelines said for mid-range, it is class 1, DAPA and EMPA, and for preserved, DAPA and EMPA is again class 1. And what after class 1? Nothing in class 2A. So there is a gap. After class 1 in mid-range there is 2B. Nothing in 2A. So actually these are so good. Now a little bit of interesting thing for last few minutes. Paradigm heart failure with ARNI. We give it in heart failure patient. What to do with diabetes? With diabetes, change in eGFR, with or without diabetes. You see, if the diabetes is there, eGFR falls more sharply. But still, ARNI reduces the slope, even in a diabetic patient. With HbA1c reduction with paradigm heart failure, can you believe it? ARNI reduces HbA1c about 0.5%, not bad at all. Time to initiate insulin in diabetes is deferred by ARNI. So like SGLT2 came as diabetic drug, became a heart drug, RNA came as a heart drug and becoming a diabetic drug. So exchange program between America and India like that. And lastly, my last 4 slides is the Finerenone, the new child in the family, fidelity trial. Why it is relevant? Because all patients were diabetic. All patients had kidney disease. And what did they do? They reduced heart failure. So it is absolutely relevant for today's talk. In a diabetic patient with renal problem, you give Finerenone and you prevent the fast heart failure. And in a significant way, p-value is 0.0018 and all-cause mortality is reduced, 0.01 is p-value. CV mortality is reduced, sudden cardiac death is reduced. Fantastic drug, isn't it? And this is the figure. Now we say a new onset atrial fibrillation is reduced with again a significant p-value. Now we question, well, I am finishing, that what happens if the patient has heart failure? Does he lose the benefit of Finerenone? No, because this came the fine arts trial which showed in mid-range and preserved ejection fraction so far, it gives huge benefit of fast hospitalization. But not yet in reduced ejection fraction. Be sure it will come by next week or the next year or the year after. So this is my final slide, and I am immensely grateful to ESC because they made the slide for me to summarize my talk. ESC implements a dedicated treatment pathway based on patient diagnosis which drives the objective of treatment. Patient comes either with cardiovascular disease or with type 2 diabetes. You immediately evaluate if he comes with a cardiovascular disease, whether he has got type 2 diabetes. You have to go all out to do all the tests. And if he comes with type 2 diabetes, you see whether there is cardiovascular disease and whether there is chronic kidney disease. So by visit 2, you have to know all the 3 status. Then, if it is confirmed that this CV patient has got diabetes, and then you go to ASCVD or heart failure. If ASCVD, GLP-1 receptor agonist and SGLT2, if heart failure, SGLT2. If the diabetic patient has got CVD, the same pathway. If the diabetic patient has got kidney disease confirmed, then you go for SGLT2 and Finerenone. So this is a fantastic summary pathway, so I stop over here.
Thank you, Soumitra. Interesting topic. Any question from the floor before? Okay. So, Shantanuda.
Sometimes we write follow-up case of T2DM and dyslipidemia, right, in my prescription. What are the components of dyslipidemia? Because we myself sometimes see the total cholesterol such and such, LDL such and such high. What are the components of dyslipidemia?
There could be any combination. Total cholesterol, LDL cholesterol, HDL, triglyceride, VLDL, LPA. There could be any one abnormal, there could be 2 abnormal, 3 abnormal, 4 abnormal. There is a typical pattern of diabetic dyslipidemia, which we cardiologists don't see, the diabetologists see. We always see LDL is high, HDL is low. Triglyceride is variable. So, though there is a typical diabetic tetrad, but I think it's still, we have to see that LDL high is still very common. HDL low is absolutely common, but we sometimes don't, we overlook because we can't help it much. And triglyceride is variable, the pattern is also variable.
Sir, another question. 20 years back, where life expectancy was 60, now it is 70.
What?
Life expectancy?
Life expectancy. In India?
Yeah, now 70 and 71. Male 70 or female 71,
okay,
right,
okay.
sir? So, before that, it is 60 or 58. So at that time, we say the premature cardiac death, that is less than 50. Now it is, what is the term of the premature cardiac death, the age limit or premature cardiac death? When you say the premature cardiac death.
Oh, acha, premature death in the family or something. It's still 60, isn't it, Shantanu? 60 for male and 65 for female. When do you call a premature cardiac death in the family history?
55 for males and
60
ESC
for
has said 60 for females.
60 for 55 and 60.
Thank you, sir.
Okay.
If you permit me, I will just want to hear from you a little different thing, not this conventional structural heart disease and diabetes as you have very nicely discussed. What about cardiac autonomic neuropathy in diabetes? That is a very important and very pertinent question.
Yes. As I said, there are a lot of other things which can happen in diabetes and heart. I could not cover all this. But autonomic neuropathy is very interesting because it's part of general neuropathy when the patient has got. And it usually comes with postural hypotension or with resting tachycardia. And this cardiac autonomy and the beat-to-beat variability of heart rate is nowadays said is a precursor of atherosclerosis or sudden cardiac death. But Dr. Ghosh, because we don't discuss it a lot, because we don't diagnose it so much.
Actually, we don't diagnose it because of our carelessness. To be very simple.
Absolutely.
Because if you take a ECG and tell the patient to take deep and slow respiration, you can immediately pick up if the patient is having cardiac autonomic neuropathy, because the bit-to-bit variation during inspiration and expiration, difference will be more than 8 to say this is normal even in the elderly.
8 per minute.
8 per minute. And if the age is low, in that case it will be still higher. Problem is, if there are 3 stages, one is bit-to-bit variation, that is because of the parasympathetic dysfunction. Further parasympathetic dysfunction produces a resting tachycardia, as you have said, because parasympathetic is gone and sympathetic is only taking up. And third stage is a fixed heart rate. Sympathetic is also denervated and that is only a fixed heart rate. Problem is, these type of patients, if given some cerebral depressants, as very often done, say with heart failure, we give morphine. In anesthesia, there is a chance of respiratory and cardiac arrest.
Okay, I didn't know that.
We had quite a few patients like that.
Oh.
And these patients had to be resuscitated.
I know.
Fortunately, they were most of them were either in the ICU or in the...
Just one question, apart from this drug-induced problem, can you really manage this patient? Is any drug you can give to correct this?
Actually, these are...
Excepting sugar control.
Degenerative things, you cannot. But
excepting early and aggressive sugar control.
You need to be very careful during the scenarios where you have to give a depressant. Say morphine, say anesthesia and all. You have to be very careful and tell about this thing.
True. Actually we overlook this thing. We never think and discuss. And
this is sometimes we land in problem. That's why I thought let me
definitely
raise this
point.
Thank
you for raising this issue.
Soumitra, diabetes, hypertrophied ventricle, SOB with near normal NT-proBNP. Any data for SGLT2, finerenone, SEMA?
Unless you look from SGLT2, you have to prove. You have to prove heart failure by some standard criteria, or you can bypass that if there is a diabetes. You can always give SGLT2 in a diabetic patient. Nobody can stop you. No judge in the world can stop you.
Same with semaglutide if he is diabetic.
Yes, absolutely. And in the back of your mind, you know that you are doing good to the patient, but there is not enough data at the moment. But it is an excuse to have diabetes to give these medicines. So that's how I practice. I always give them, but with knowing that I am safe and I am doing good for the patient.
Because
and
in clinical practice, we are not doing this stress diastology or stress-induced right heart catheterization. At least I don't practice.
This type A heart failure is now huge controversy, that whether we should already give the proactive medicines. Because type A means you have got hypertension, obesity, diabetes, and dyslipidemia or obesity or smoking or family history, these 5. So whether to treat with this hypertension, with ARNI, this diabetes with SGLT2 to GLP, this obesity with GLP already, and whether that will prevent from A to C progression, not enough data. We discussed with the international level, they said very difficult to prove something in a primary prevention setup. Because
And
you need
one more question,
so many patients.
Since you were in a LDL symposia, I included you. Diabetes with high LDL, which anti-diabetic drug will cause less number of new onset diabetes or less worsening of HbA1c? Any LDL lowering agents? Statin we know is bad for.
Statin increases.
So any other LDL lowering drug in a diabetic patient which is particularly pre-diabetic?
You told SGLT2 inhibitor has already proved, particularly dapagliflozin, not EMPA, that even in the pre-diabetic phase if you give, not even pre-diabetic, no diabetic, pre-diabetic means 5.6, 6.5 or whatever is your HbA1c, even below that level, there is a slower progression to diabetes with SGLT2 inhibitor, particularly shown in dapagliflozin.
And LDL lowering therapies which causes less diabetes or
I'm not sure, you told, na?
ezetimibe, bempedoic, inclisiran.
Inclisiran, I think, is there already touted for that.
So these are the
Inclisiran is already touted.
newer drug which do not cause or causes less number of.
And you see, I showed here that RNA also reduces new onset diabetes.
So we'll discuss after this.
Yeah.
So thank you, Soumitra, for having great
thank you for
presentation. Just wait,
accommodating me. Thanks.
I'll request Professor Shantanu Guha to felicitate you.
Thank.
Dr. Shantanu.
Thank you, Speaker, sir, Professor Dr. Soumitra Roy, and I request Dr. Shantanu Guha to kindly felicitate him. Thank you so much, sir, for your insightful presentation. With this, I would also request Dr. B.P. Pandey to felicitate Dr. Shantanu Guha for joining today as chairperson.
So we continue with our LDL symposia, and now we'll have a panel discussion. Program list. No, So we have already discussed the incidence and the prevalence of a lipid disorder or a burden of atherosclerotic cardiovascular disease. So next I'd like from Dr. Arijit Ghosh. No. Panel discussion. So we'd like to know, Dr. Arijit Ghosh, what are the newer targets for treatment in lipid lowering therapy, particularly the LAI or CSI guidelines?
So now, the Lipid Association of India and the CSI has, in 2023, has come up with an expert consensus which focuses on very aggressive lipid lowering. So we as interventional cardiologists who deal with patients of ACS, very unfortunate to say that when this patient gets back to their primary care physician, the first drug which is curtailed is high dose of statin. So we often find our patients coming back with a statin dosage of 20 at best. Even most of the cases, they are continued on 10. So this is on what the CSI has given a lot of stress. So we are not talking about lower is the better. And this is quite true in secondary prevention, and there are various trials to say that this is equally true for primary prevention also. So in the CSI guideline, what we find is that a patient who has landed up with an ACS, the LDL goal should be less than 55, but there should be a word of caution. There should be a non-fasting lipid profile when the patient is suffering an acute heart attack, and depending on the baseline LDL, there should be a 50% reduction. So the actual term should be over the baseline, there should be a more than 50% reduction and an LDL of less than 55. Say a patient who is having a baseline LDL of 60, so his target should be 30, not 55. So both of these two criteria should be met. And the CSI is also very particular about achieving this target within the next 12 weeks. That is, they are asking for repeating the lipid profile after 1 month, after 8 weeks and 12 weeks. And within a span of 12 weeks, you should be reaching the target. If you are not reaching the target of less than 55 or less than 50% reduction over the baseline, you should be subsequently adding ezetimibe, and now we should be adding ezetimibe on the top of highest load of statins since the index event. So a patient who is having an MI, according to the CSI expert consensus panel, what we find is you should be adding rosuvastatin 40 milligrams or atorvastatin 80 milligrams along with ezetimibe 10 milligrams. So this combination should be there since the outset. After 4 weeks, you should be having an account whether the patient has achieved the goal. If the patient has not achieved the goal, you should be adding bempedoic acid. And after 12 weeks, if the patient has still not achieved the goal, you can think of PCSK9 inhibitor or a PCSK9 inhibitor or Inclisiran for that matter.
Let me ask Dr. Sabyasachi. Suppose patient is already on a highest possible dose of statin, which is tolerating an ezetimibe, and still his LDL is not to the target. Target means it's not touching below 55. So how you are going to manage that patient?
Fine. Just giving, prior to giving the answer, so patient has not reached the target. Our target depends on the scenario, it is below 55 or below 30. If highest dose of statin, bempedoic and the ezetimibe, we are not bringing down the lipid lowering goal, we have to add something, PCSK9 inhibitors. So still now, we had the PCSK9 inhibitors in the form of antibody. That is in the market, Repatha, Evolocumab, all these things, but that needed to have the dose every 15 days or in the 3 months interval. Now we have the short inhibitory RNA molecules, that is Inclisiran, and it is quite smart enough. After the first 3 months interval, every 6 monthly we can go on adding this molecule, and it has a robust LDL lowering effect that can bring down the LDL lowering from the point where you have started. At least you can expect the 50% with the reduction of the LDL lowering from the time of the point you are starting the dose. Now I have one question. When our LDL is the target, so is it needed to perform the lipid, the examination of lipid in the non-fasting level or fasting? Does it make any changes if our LDL is the target, fasting and non-fasting?
No. So when LDL is the target, probably we don't require a fasting lipid profile. So fasting lipid profiles are usually the thing which is influenced by fasting or non-fasting state is the triglycerides. So if you are really wanting to have a very good measure of the triglyceride level, then you should be thinking of a fasting lipid profile. But one thing is that it has been corroborated that the non-fasting triglycerides are much more relevant with the future cardiovascular event. So just doing a fasting lipid profile at this current day and age, I think is not a very good idea. I know what sir will be.
Any your comment?
Yeah, so I think I'll make it a little more simple, sir. So when we talk about fasting and non-fasting, we are predominantly looking at triglycerides, of course, but it's easier to do a non-fasting because it's easier for patients, it's easier for the doctor. But when you are doing a non-fasting, and let's say your triglycerides is more than 400, it's not like you cannot interpret that lipid report. So what you really look at, you look at other targets rather than just the LDL. You look at your non-HDL targets, which basically is a larger marker of your all ApoB containing proteins. So that basically gives you a better target to analyze. So you can treat it accordingly. So your target becomes not the LDL, it becomes the non-HDL. So that is what you should be looking at when you're looking at a non-fasting report. But predominantly with patients with ACS, we still prefer, as far as the CSI guidelines is concerned, to have a fasting lipid profile within the hospital before you start. And as Arijit said, so you have to look at, we've started to now load patients not just with atorvastatin, but atorvastatin plus an ezetimibe, and try to get them 2 targets within the first 3 months. So we are looking at very aggressive therapy.
I want to add one thing. As Ayan was telling, when we are dealing with a patient who is already on statin, where the LDL level is already lowered, say LDL level is around 70, in those patients, most of the guidelines recommend to look at non-HDL levels. And non-HDL levels do not require fasting samples. So when you are taking a non-HDL or when you are looking at non-HDL levels, you do not require a fasting sample. And another thing I want to add, as Arijit was telling, regarding the 12 weeks by which we need to reduce the dose of the LDLs, we need to reduce the level of LDLs. The idea is that within 90 days of a first event, the chance of having a recurrent event is around 10 to 15%. This is the reason why CSI or the Lipid Association of India guidelines recommend that you should lower the level of LDLs by 12 weeks to the cutoff level. So this is the reason why the 12 weeks term has came out.
So Dr. Ayan, what about this concept of time in range? Just like sugar, what about LDL time in range? So how early, how quickly, and how robustly you are going to bring it down?
So I believe so we are looking at as aggressive as possible. So I mean, so it is as soon as you bring LDL down, it is probably the atherogenic particle you want to bring down to the lowest level possible so that you can prevent that next event. Because I think we've seen multiple studies where despite our current therapy, the residual CV risk today is currently to the tune of about 20 to 30%, despite maximal therapy that we give to these patients. So which is why I think I often see patients nowadays, especially after the new CSI guidelines, after we've started loading patients with ezetimibe and full dose of atorva and rosuvastatin, we are having patients within 12 weeks with LDLs of 29, 30, which we weren't doing before, because previously we were not adding ezetimibe immediately, and sometimes we were also a little cautious with statins. But nowadays we are aggressive. But I think that is probably the way forward, because the general myth that low LDLs can cause a lot of problems is something that needs to be done away with, because there is no J curve for an LDL. So LDL as low as possible.
So like in heart failure, we give all 4 drugs in smaller possible doses. So something like that with LDL also, at least 2 or 3 agents simultaneously, and then you can de-escalate.
And as soon
any
as
trial
possible.
evidence for that? At least for Inclisiran or Evolocumab?
For Inclisiran, yes, sir, we have the Orion program. So the Orion, as well as I think the Victorian studies will come in initially, the Victorian Initiate study. They're basically looking at the same part. And so there we have shown that within 12 weeks, so when you add Inclisiran, actually you are getting it even before that. So it's probably within the first month we are down to less than 50%. So 52% reductions in LDL, which is quite massive.
Dr. Arijit, any inter-individual variability like non-responder, poor responder, or hyper-responder to statins, Evolocumab, Inclisiran, any hindsight on that? Or all are good responders?
The majority of our patients that come to us already have a very low LDL. To my, what I have experienced all over these years is that even despite having a high dose of statin, the LDL cholesterol hovers around somewhere around 60 and 70, even with the highest dose of statins. So it becomes, if you are really chasing the target, it becomes difficult even after the addition of ezetimibe, which logically should be bringing down the LDL cholesterol further down up to an extent of 10 to 15%. So these are the things that we often see. And yes, the inter-individual variability of statin response are still there. But the thing is that we usually don't see somebody who is not at all responding to the therapy. They do respond, but most of them do respond partially at times.
I just once when you said non-responders, I think homozygous familial hypercholesterolemia is one part of the LDL puzzle which we haven't been able to address. So even Inclisiran doesn't work. So one study where it really doesn't work. So that is one part, which is, and the other part is patients with high lipoprotein A. So remember, even if we do a lot of LDL reduction, even despite that, we find a lot of patients have high LPS, because with current molecules, the reduction of LPS is only to the tune of 20 to 30%, if I'm not wrong.
Because I ask this because in my practice, I have seen LDL of 200 getting down to 50 just with 40 rosuvastatin.
Absolutely.
Whereas I have seen LDL of 140 not coming below 100 with 40. So there is an inter-individual variability, and literature says 5 to 40% with statin. And Inclisiran is not different. They also have in this German network analysis, they have inter-individual variability. Dr. Bappaditya, when do you measure apolipoprotein B or LPA in your practice?
These situations are in patients where there is hypertriglyceridemia, in patients who are obese, in diabetes, and as I was already telling, in patients who are already on treatment with statins and LDL level is around 70-80. These are the four situations. Where measurement of apolipoprotein B is of immense value. And lipoprotein little a measurement is very essential in patients who have a family history of premature ASCVD, or in patients who have recurrent events of ASCVD, say 2 events in an interval of 2 years. These are the patients where lipoprotein little a measurement is important.
I just want to ask a question to all of you. What is your views on that? Regarding the recent CSI guideline and the guideline, or rather the consensus statement of LAI in patients with ACS. In ACS, as we know, the primary objective, particularly a patient with STEMI, is to revascularize, to open up the artery and revascularize. That is a time-bound program. You need to do it as early as possible, preferably within first 5-6 hours. You get the best results. Not after for 12 hours, obviously the result dies down a bit. For lipids, there is no such time-bound thing that it needs to be reduced within first 24 hours or 48 hours to a level which is comfortable to the patient and for everybody. So still now all the international guidelines like ESC and ACC-AHA, they recommend start with high intensity statin, particularly the ESC guideline. After 4 weeks, repeat the lipid profile. If it is not below 55, add up ezetimibe. So what is wrong if we follow the same thing rather than adding up ezetimibe from the very word go? That is one. Secondly, ezetimibe has been incorporated because of the Improve It trial. Basically, that was the fundamental or the most major trial which showed that reducing it to around 53 is better than when it was around 67 with simvastatin alone. Simvastatin plus ezetimibe reduced it to 53. Now, this trial itself is not a very proper trial. This is a rather a faulty trial. That the dosage, 80 milligram simvastatin has been banned. We no longer use that thing. And the baseline LDL in this particular group was around 100. It was very low from the beginning. So without a properly designed trial, extrapolating the results of 1 or 2 trials and giving it from the beginning, do you feel that this is necessary? I'm just asking this question.
Yeah, my answer is definitely yes, because all the trials you have quoted were published before 2019. So after 2019, whatever trials we have, they are very small studies and follow-up is not that. Reason I am saying, because there is a lot of retrospective analysis, particularly from Korean, which was published only few months back. They assessed if you have a LDL below 70, if you have LDL below 55, and they have shown that event-free survival, revascularization-free survival is better if your LDL is below 55 compared to below 70. So this is 22 months follow-up. But it does not say that you have to bring it down to 3 months or within 6 months.
I could not perhaps put the question properly. I am not questioning about below 55. I am telling it should be down to below 55 always in all patients with ACS. Question is to start ezetimibe from the word go or add it up after 1 month as suggested by the Europeans.
I think it will not make a difference, but in clinical practice, where the dropout rate is so high, reception to your advice is very poor once they are stable. So just like change has been in a diabetes forum, in a hypertensive, why 1 month lowering BP is better than 3 months lowering, Valiant trial, amlodipine versus valsartan. Same concept is same. The trial will come subsequently just to improve compliance, reduce the cost, because we know whatever you do by step care approach, 80% of the time you will not be below 55. So why waste time? And what is the price you are paying? Apart from the consultation fee, 4 months delayed appointment to the specialist. So there are a lot of issues without any side effect.
It is only 4 months.
Yeah. So without any side effect. That is why non-fasting concept came, because we don't want to lose those patients. So non-fasting lipid profile is a routine in all the corporate hospital, at least. Because you know you have to give a statin, whatever is the LDL level. So get it done. So there is no harm. If you are practicing a science which is not causing harm, it's fine.
My only question is, adding a drug, if it is not necessary, should not be added. That is my point.
You can always de-escalate.
We can escalate. Rather, since there is no time-bound program that it has to be lowered by 20 days to have a beneficial effect. If tomorrow a trial comes that lowering lipids within first 2 weeks improves the outcome, obviously there won't be any question of adding ezetimibe from the word go. But since we don't have any such trial, I think I will prefer to add it at 4 weeks if it doesn't reach.
So I think I'll request Dr. Ayan. He has a small presentation which is case-based. So next 15 minutes, we have 15 more minutes. So we can learn from the case presentation how in real practice we can follow, and then we'll conclude after 10 to 15 minutes. And I'll request the audience to interact. You can stop Ayan in between if you have any doubt on the case. Over to you, Ayan.
Hello. Thank you, Pandey sir, for this invitation. And I'll quickly take you through some cases with Inclisiran. I think real-world cases as to how we are actually giving Inclisiran in certain patients. Of course, there is some scope for criticism in certain places. So 1 in 10 is report a second MI or a stroke or a CV death within the first 100 days after experience in MI. So we are looking at reducing residual risk, as we call it. Of course, one of the top modifiable risk factors is LDL-C. And we know that in a lot of patients, due to various causes, we do not reach LDL-C goals. If you look at the current guidelines, we are very aggressive as far as the goals directed treatment is concerned. So if you look at extremely high risk and very high risk patients, we are looking at goals of less than 55 and less than 40. Now something is similarly echoed in the LAI consensus data too, where you are looking at 50, sometimes even we are looking at less than 30 in very high risk patients. Quickly come to some cases. We had a 41-year-old male. Now he's a banker. He's been having periodic medical checkups biannually, which means every 2 years, and he's been having some cholesterol. Exact reports he wasn't able to produce, but he was started on rosuvastatin 2 years back and is compliant with his medicines. We have a significant family history. Father underwent a bypass at the age of 46 years, by all means considered to be premature coronary artery disease. Father's brother, that is his uncle, died of a fatal MI at the age of 52 years. Elder brother has had a PTC at the age of 50 years. And this patient was admitted to our emergency with an evolved anterior wall MI of almost 12 hours in cardiogenic shock with severe respiratory distress and a room air saturation of 78%. So to summarize, we have a 41-year-old manker. Remember, no conventional comorbids. He's not a smoker, he's not a diabetic, he's not a hypertensive, he's not on any medicines except for a rosuvastatin of 10 milligrams, which we very commonly see in a lot of patients in our kind of practice. And what is standing out in his history is the strong nature of family history, the premature kind of family history. It's not just any kind of family history. We're looking at disease which was happening below 50, and you see that even his uncle has died of a fatal MI at the age of 52 years. Now, see this patient, so we sent a fasting lipid profile before we decided to stabilize him, and you can see what we are echoing. So on rosuvastatin of 10 milligrams, his LDL is 190. Triglycerides are 150, HDL is 35, and a total cholesterol 225. We did an angiography after stabilization. Again, something very concerning. See, there's a subtotal LAD 90%, RCA diffuse disease, LCX diffuse disease. So this is multi-vessel coronary artery disease. This is not normal coronary artery. This tells you this is malignant coronary artery disease probably, something that we generally seen in forms of congenital dyslipidemias, etc. He already has LV dysfunction with an EF of 45%, grade 2 LVDD. And once stabilized, he underwent PCI to the LAD. Of course, we started him on rosuvastatin 40 plus ezetimibe. Given his family history, we do think that given our current consensus of treating patients very aggressively, we decided to give him the chance of taking Inclisiran. So apart from that, you see he's already on standard heart failure medications. That includes a ramipril of 2.5, a ticagrelor of 90 milligrams twice daily, aspirin of 75 milligrams, SGLT2 furosemide plus spironolactone, and a carvedilol of 6.25 milligrams twice daily. Now with this, on his first follow-up visit, so you see post 2 months, his LDL-C currently is 21, his triglycerides are down to 95. He of course hasn't had any major side effects. He's currently NYHA class 2, he is back to work, and we know there's modest effects on triglycerides. Pandey sir, do you want me to stop here or do you want me to continue?
One more case here.
We have one more case. Yeah, so next case, again interesting case, 51 year, please note the ages, 51-year male. This patient has standard comorbidities. He's a hypertensive, diabetes, obese, active smoker, works in a large MNC based out of Thailand, had a recent anterior MI while working in Bangladesh, underwent PTCA to a large D1. He has prior history of 2 other stentings. He's already had one in 2000 in Bangalore to the right coronary artery. He's had another AC in 2014 requiring a PTCA stenting to the LCX, and he was on a beta blocker. Please look at the drugs again. Telmisartan of 40, 90 milligrams of ticagrelor, aspirin of 75, already on rosuvastatin of 40 and ezetimibe of 10, not for the last 2 weeks but for the last 1 year. And he has RWMA, and he's come for a routine evaluation with me because he wanted to check whether if there's more to be done for him. Now when we did his LDL-C, remember, despite of rosuvastatin of 40 and an ezetimibe of 10, is currently hanging around 91, and he has a lipoprotein A of 95 milligrams per deciliter. Of course, his echo shows an EF of 45, ECG is old inferior wall MI, he does not have any current symptoms. He was also started on Inclisiran, and I think he is a perfect candidate for Inclisiran in these kind of patients, apart from his standard of care. Now after 1 month, so this is within 1 month, we brought his LDL-C down to 16 and his LPA is reduced from 95 to 66, which is acceptable. That is what we expect Inclisiran to do. So again, this is well tolerated, but I think these are cases where we would like to initiate Inclisiran. The problem is of course that this needs to be taken at 3 months and then again after every 6 months. So a significance of PCSK9 in recurrent events is, of course, we are looking at targets of less than 40. If you go by the LAI guidelines, I think it should be less than 30. In fact, in certain places, we would, once you've reached to 16, it's not like you take off medicines or you decided to withdraw medicines. Please remember, the lower the LDL in these kind of patients, probably the better they are. Of course, still pelacarsen is available in our kind of setup. I think LPA is an unaddressed part of the LDL puzzle, which we'll have to think about. How does Inclisiran fit into clinical practice? Twice yearly doses. It achieves your goals very quickly, up to 52% reduction within the first week. And it's effective and sustained LDL-C reduction, and it's got a very well tolerated safety profile. Thank you so much, sir.
Join us here. I'll request Dr. Sabyasachi Paul to have his small presentation translating guideline into clinical practice with Inclisiran. Yeah. So LPA is nowadays important, at least the extended lipid profile we send on first medical contact, at least in acute coronary syndrome, which includes your lipid profile, apolipoprotein B, as well as LPA.
So, one thing I find to be stressed is the next patient who had a repeat event within 2 years. So he, despite being on optimally or the maximally tolerated recommended dose of statin, this patient had a repeat event. So in this group of patients, the target should be as low as 40. So this is what should be stressed upon. And if you go to the LI guideline, probably the goal is even less. It is less than 30. So this should be the message, that premature truncation of the dosage of statins and discontinuation of statin to a very low dose should not be done.
Yes. And in fact, we have 10,000 cases collected from Lipid Association of India, which will be published shortly, I think in 3 to 6 month time. And from our center, we have seen around 50% patients are not on target despite triple drug therapy. Triple means bempedoic, ezetimibe, and statin. Yeah, Dr. Sabyasachi Paul.
Good afternoon. Look, actually, the knowledge of our lipids is changing gradually year by year. Probably the concept that we are here presenting to you and hammering you with the same cardiologist will come after 10 years, will tell you completely different story. So I am sharing one experience. We doctors, we learn every day. I learned a good lesson from one of my patients. So, listen a good story. So actually it was my initial day's practice. I was starting my OPD. So one father and son, they entered into my chamber. So obviously I thought father will be the patient. So actually the son was the patient. So father brought the son to have the opinion from me. Probably it is quite obvious and quite frequent nowadays. Apparently healthy parents are bringing the unhealthy, their kids. Very thoughtful that what the society we are having in future. Anyhow, on that particular day, father came, started there. Before the son speaks anything, father shouted about the son, he is doing this, that. I took some time to understand what is the actual problem. Problem was, just like the mark sheet, the son's reports was abnormal, so the father was very furious. So now I have to tell about the son. The son was the IIT pass out, IIM pass out, was working in the USA. He was very humble, polite, but he was a knowledge geek. You know what is called geek? Volatile, versatile, he was just like a black hole of knowledge. So after a few times when I understood the son's problem, sons understood my problem, that I am not following his father. Okay? So now I asked the son, what is your problem? So I don't have any problem, I am totally fine, fit and fine. Father has brought to me to have the opinion from you. But I want to ask one thing, sir, because I was searching different things. So he took out the small tablet. He searched in the last 10 to 15 days so many of journals that I have not read in my lifetime of that particular time. So many of journals of that particular time that was totally barred because of the password. But he had the access. He searched naturals, he searched very basic thing, very translational research. So I am asking another question. Have you ever been nervous in front of your patient because your patient is more learned than you? I felt nervous that time. So he asked me a very genuine question, sir, my father is shouting to me that my lifestyle is bad. You can tell me what is actually the normal LDL level. I can getting the normal, this cholesterol level, this triglycerides, all these things. What is the normal LDL level? I was dumbfounded, okay. So because the similar things in the DM time, I had them in mind, but I could not had the time to search of it. So I am telling, look, actually it is the preferred that we term the preferable limit, but I can tell you the above which level, in the normal person also, the LDL starts damage you. So that particular chap showed me different trials, different journals, and I learned good things from that particular non-medical chap. Severely intelligent non-medical chap, he showed me the different trials, the journals, and he asked with the document, sir, see that this journal has showed me same LDL level,
say the 150 LDL level, some person having multiple critical blocks, some person is completely fit and fine. So why my father is so anxious? Why you doctors are so anxious about the LDL levels? Because I think LDL is not everything. Completely he was right. And I had the concept. But that particular time, that particular point, my knowledge was not so deep to argue with that severely knowledge person what is actually the concept. So anyhow, that chap has the LDL, but from then onwards, I started learning. I started learning from that day not to pass the exam, but to know the subject. So actually what happens, whatever the lecture we are giving in front of you, whatever the practice we are going in front of you and telling you to practice and follow us, you know, the lipid still a mystery. The same LDL level of 130, somebody have the multiple of disease, first-level disease, and somebody will fit and fine. So lipids is not the culprit to develop the heart disease till the person develop the plaque or ruptured or presented in you. The story reverses as soon as the person develop the tendency to and make the plaques. So we are getting the patient when there is a plaque ruptured. The person who has developed the tendency or acquired the tendency where because of the multiple other risk factors, LDL has started entering into his endotheliums and started the plaques. So a person who has not developed the plaques or has not been identified the plaques or has not presented with the plaque rupture, so LDL story is different. Person who has developed the plaque and caused the disease, their LDL story is different. So mind it, our lesson to you is to consider, we are talking about those person who has already developed ASCVD patients. So person who has developed the tendency, we need to know higher the LDL till nowadays is more the plaque progression. Whatever the plaque he has developed, that will increase, and whatever the plaque is not there, it will develop or the progress. So more the level, whatever the LDL level at which they are presenting in front of us or you, whether it is 90, whether it is 110, whether it is very benign, 76, that LDL levels is higher for particular that person. We have to bring it down. And to bring it down is actually another frustrating story that sir has already told, that it is a interpersonal variability. Multiple causes are there. Sometimes it is the compliance, and forget about the compliance. Patient is taking high dose of statin, ezetimibe, bempedoic acids. Still, the person of the 130 LDL cholesterol, I cannot bringing down below 60. And the person cannot afford the PCSK9 inhibitors. It is a, I do not know, there is a good many of patient in your practice, you will see, the patient presented initially is 160 with the 40 mg of rosuvastatin or the 40 mg of atorvastatin, it is coming below 30. And the Suroxan last slide, it is telling low, means below 30. They are not mentioning the measure, probably below 10 also. But the very high dose of the statin, but it is not coming down at the proper level. So in this field, so in this respect, please mind it, the person who can afford PCSK9 inhibitor is a game changer. Is a game changer. PCSK9 inhibitors usually comes in the two forms. One is antibody related, that was present in the last 5 years, evolocumab, alodicumab, and the Inclisiran. This Inclisiran, the mechanism, I am just showing you the mechanism. This Inclisiran is actually short interfering RNA inhibitor. You know, what does this mean this? Actually, we know the pharmacodynamics, pharmacokinetics, but we just forget the genetics. The gene, there is some different types of molecules is coming to altering our gene. We have the DNA. Every person have the own structural DNA and have the DNA template that is particular for that person. every person develops some protein through the DNA templates. Your body is different because your DNA is different from mine. But your body organ specific, some protein will be generated in every human beings. Our saliva will produce from the salivary gland. Insulin will be produced from the pancreas, even if genetically the two person is different. So this PCSK9, this is generated from it is produced in the liver. It is produced in the liver. So hepatocytes is producing this PCSK9. What does the PCSK9 forms? After the generation, this PCSK9, it actually reduces the LDL receptor. And if the LDL receptor is reduced in the hepatocytes, LDL in the blood cannot be entered into the liver, so the number of LDL is more. When this short interfering RNA is given into that person, they silence the gene that produce this PCSK9 by the small or short inhibitory RNA. This PCSK9, this protein is formed from the DNA by a short 20 to 24 templates protein by the M messenger RNA. This short interfering RNA there enters and blocks this messenger RNA and do not allow the hepatocyte to produce for a certain period this PCSK9. So what is its benefit? If you give the Inclisiran, it is a 300 mg dose, subcutaneous mode. If it is given today, within the 48 hours, it is not available in the blood, completely taken up by the liver. But you do not expect the PCSK9, this Inclisiran will start showing its action immediately. 14 days is required to have its action initiated or to have the LDL lowering effect, because even if it stops generating the PCSK9 from today, existing PCSK that is present in the liver, they go on working for next two weeks around, and its effect starts after 2 weeks, 14 days. This PCSK9, after giving the day 1 dose, needs another dose after 90 days to have the increase in the RNA inhibiting complex. What happens when we are giving the short inhibitory RNA? It is blocking the messenger RNA by a inhibitor complex. This inhibitor complex activity after the 90 days, it remains for 6 months and do not allow the liver to generate another mRNA formations for the PCSK9 proteins. So every 6 monthly